Hi everyone, I'm Mohamed Draz again, and this is the Brain, Spine and Beyond video podcast. This is your space for learning, innovation, and invention. Today we have a special guest. I'm sure we will have a very interesting discussion with him. We have Dr. Lali Sekhon. Dr. Lali, thanks for joining us today. He is a neurosurgeon and he is the founder and chief medical officer of SpinePoint. Thanks for taking the time to come.
How about you, Ben? My pleasure, Mohammed. Thank you for spending a little bit of time with me, and thank you for the invite to come along and have a chat.
Thank you. So I will start my first question just to get through your neurosurgical career, so that we know more about you, and if you want to share some learnings across, through your journey as a neurosurgeon.
Yeah, I did medical school in Australia. And around about the end of medical school, I wanted to become a neurosurgeon. I was influenced by people that I'd seen, and I started orienting it toward it pretty quickly. So I did an internship year, then went and did a PhD with a neurosurgeon, and that was in cerebral blood flow. So that was great. It was basic science, and I finished that, then came back, did neurosurgery residency, finished it in Australia. We can go overseas for our last 6 months, so I went to Mayo Clinic in Mayo Clinic in Minnesota. And that was a neurosurgery fellowship. And then I went to Toronto, and that was a spine fellowship with orthopedic surgery and spine surgery. So 2 fellowships, PhD along the way. I then went back into academic neurosurgery in Australia. I was in academics for about 5 years, published a bunch. And my wife, who was from the Bay Area, wanted to come back and live close to the family. So that's how I ended up in a place called Reno, Nevada, which most people could not point to on a map, but it's a beautiful area. And basically, if you find San Francisco and you go east, there's a mountain range with lots of ski resorts and a place called Lake Tahoe, and Reno is right next to it. So it's a mountain city. And I've been in private practice in Reno now for 20 years.
Interesting. Okay, that's a long journey. And it's quite an interesting mix to go from academic neurosurgery. And you don't do like any more academic work at the moment.
I used to do a lot of it, and I used to like publishing. Publishing's a bit of a mixed bag now. In Australia, you publish because you had something interesting to say. If you get an academic job in the US, you've got to put a number of publications out. The other thing I noticed was it's easier to get publications now than it ever was, because there's a lot of, pay for it and we'll peer review it and you can publish it. And so the quality's gone down. So I got involved in education a fair amount. I was involved with the AO. I'm wearing this shirt today. And so I did a lot of resident training, a lot of registrar, fellow training. And, but I was in private practice. I still have that, as an academic neurosurgeon, we have a curiosity. And, I never lost that. But in private practice, you just grind it. And so you end up doing both. It's kind of interesting because it's always like academic neurosurgeons can't really operate. Private practice guys do it. And don't tell them I said that.
That's all recorded now. Don't worry.
But in private practice, you just grind it and you do just a boatload of cases. And often the best surgeons are not the ones who are on the podium. They're the ones who are grinding it out just case after case after case. And they never talk about it and they never publish it, but they do a ton. So, it's been an interesting road, but I bet you there's not a neurosurgeon out there who doesn't have an interesting road as they navigate their career.
It's interesting. It's just that I've never seen before like an academic neurosurgeon who kind of made that shift towards completely private practice. And they always continue doing the academic work for a long time.
Yep. Blame my wife for that one. Okay. Because that's why I looked around at academic jobs and ended up the private practice job was the best. But again, I don't think of, it's like, people say, well, you did a PhD in cerebral blood flow and you're a spine surgeon. What a waste of time. And the answer is no. You learn critical analysis. You learn how to solve problems. And then you apply that to whatever you do. And so I think as an academic neurosurgeon, we have curiosity. We're asking questions. We're saying, hey, is this the best way of doing it? Can I improve it? And you bring that mindset to private practice. So, there's something to gain from everything that we do. I never look at an experience as wasted. I just think of it as another lesson it gives you a few more skill sets.
And did you always want to be a neurosurgeon or a surgeon of any kind?
I think so. So every neurosurgeon says this. I thought I chose neurosurgery because I thought it was the most challenging thing. And what I saw was, if you become a general surgeon, there's a standard that's expected. But with neurosurgery, it's all over the map. And you go into for a neurosurgical procedure, and the skill set of the surgeon really mattered. And so if you had a surgeon that was invested in what they do and do it well, the outcomes, could potentially be better in those hands. So I wanted to do something challenging like cardiothoracic or neurosurgery. And if I hadn't done that, I probably would have been, radiology or something. Surgery itself, it's okay. I'm not one of these people who just likes to sit in the operating room for, 20 hours and that's what you do. But to me, it was the challenge. And then when I got exposed to the right people, the neurosurgeons, I found them inspirational. I found them good role models, and I wanted to be like them. And that was the local community that I worked with.
Interesting, because I mean, myself, I never thought that I could be anything apart from being a surgeon, not a neurosurgeon, because I always thought, I need to do something with my hands. That was.
Yeah, I'm terrible. See, if I have to hammer a nail in at home, it's going to go bent. If I have to put a screw in the wall, the screw will strip. At home, they talk about spine surgeons and orthopedic surgeons and how they like working with their hands and have workshops and stuff. Not me. I have my computer set up, and I'm a nerd, and I am not good with my hands outside of the operating.
Great. So you mentioned that you had your fellowship was partly neurosurgery, partly orthopedic. That's similar to what I have done so far, and I find it very interesting, especially coming from neurosurgery, to go to the orthopedic side, because I've learned a lot from them, to be honest. What's your take on this? And how did you find the orthopedic surgeons operating in comparison to neurosurgeons and vice versa? And what did you learn from them?
It's different. So I think out of the gate, the neurosurgeons probably have the advantage. So there are publications where in the American system, neurosurgeons have done 6 times as many cases as orthopedic surgeons by the time they finish residency. And neurosurgery is 7 years. You start doing spine from day one. Orthopedics is 5 years. So it happens. But then I think a lot of it is the growth you have during your career. So orthopedic surgeons, neurosurgeons tend to be very much direct decompression surgeons, and they're very comfortable working around the dura, nerve roots. We're used to opening the dura for everything, craniocervical junction, vertebral artery. We're all good with that. Orthopedic surgeons are a little less comfortable around the dura. Doesn't mean they're not, but it just means they're a little bit less comfortable. And they'll prefer more indirect decompression. So, I see that in the American community is orthopedic surgeons like doing indirect decompressions, whether they're ALIFs or laterals. And, but I think over time, they probably get close. There are excellent orthopedic surgeons that I would trust with my back, and they're excellent neurosurgeons, and there are terrible neurosurgeons who do spine, who probably were in the old school of mainly cranial and simple decompression. So like everything, there's a mixture. The orthopedic surgeons are probably a little bit more focused on indirect decompression, sagittal balance. Neurosurgeons are as well. But I think we're a little bit more focused on direct decompression. And we focus more on that, neurological deficits and correction of that.
Yeah. Do you think that anyone who wants to train as a spine surgeon should have combined fellowship? Do you think it makes a difference, or do you think just a neurosurgery or just orthopedic will be enough?
Boy, I think it's a good question. So, I am in an orthopedic group now, and we'll probably touch on that. So I'm the only neurosurgeon. And I remember one of my partners who's very good was talking to a medical student and said, if you're going to become a spine surgeon, go the neurosurgical pathway, just because you get more exposure to things. So I think the answer is the key is getting exposed to lots of different opinions. And so in the Australian system, we moved hospitals. And so at one hospital, they would say, never do this. At the next hospital, they would say, always do this. And then you realized there's lots of ways to do it, and you just have to be comfortable in knowing how to do it. And I think the same thing, orthopedic surgeons in their fellowship should get exposed to neurosurgeons, and neurosurgeons should get exposed to orthopedic surgeons just to learn the different mindsets, because they're a little bit different. We're all trying to fix and help patients, but we both come from a little bit of a different mindset to it.
That's true. Okay, let's jump to another thing which you do a lot, which is the use of social media. You're big on using LinkedIn specifically. I don't know if you use anything else.
Yeah. So here's what happened. I did an MBA during COVID. And one of the things in the MBA one of our modules was personal branding. And this is important for everyone. What's your brand? And so they forced us to set up our social media platforms, Twitter, Instagram, Facebook, LinkedIn. And we had to post a certain number of times a day. Twitter was a complete zoo. And, I'd post something like wear a mask, something pretty benign. And I'd get in arguments with, Honky Tonk 224. And then Honky Tonk 224 would say, "You're not even a physician. You're a robot." And I realized that Twitter was not the best place to interact with people because you don't know who they are. The nice thing about LinkedIn is most people on there are bots on there, as you've probably seen in your direct messages, when they contact you and say, "Hey, you and I have something in common. What's your WhatsApp number?" But the majority of people on LinkedIn are professional. You know who they are. There's a little bit of courtesy to it. And I think the description that someone had given during the MBA was Twitter is like going to Walmart. And I'm sure there's a Scottish equivalent of Walmart, which is a budget supermarket. You don't know who you run into there. And you can say the name of it if you like, but I don't know what it is. I don't know if it's Tesco's or what, but imagine going to that one and you run into people that you don't normally run into. That's Twitter. And LinkedIn is like meeting colleagues after work for a drink and just having a discussion. So I started posting mainly because I just have questions. I mean, and you'd have an interesting case and I'd have some sort of thought about anything we talk about and see what the response was. And by and large, people have been very receptive to it. I just try to put up things that are interesting. So, like all of us, there's 10 journals I get a month. And if I see an interesting article, I try to put it up and say, what do you think? Or if there's a technology or an interesting technique or industry, just stuff to talk about. But it seems to have had some traction and here we are.
And would you say that it helped you in any way in your career or in your work or something like that?
So I think, the question you got to ask yourself is, what is your goal? So my career is pretty advanced now, and I'm fortunate enough that I have plenty of work, get referrals mostly by word of mouth. So I don't need to use social media for referrals. And some physicians will, and you've seen Instagram posts, and I don't dance, and I really don't want to put my face out there. I think what I wanted to come across was as genuine, authentic, credible, decent. And inadvertently, I think that probably helps the startups because I don't push my startups. I'll let them speak for themselves. But I think if you can come across as authentic and genuine, I think there's some value to that. And I'm not always right about what I put up there, but I have an opinion. And I think that's all we're trying to do is just have an opinion, which is unbiased. I don't try to favor one company over another. I mean, everyone has a role and, we don't all have navigation and O-arms and all the rest of it. So you got to respect what people are doing out there with the resources they've got. But for me, there's no agenda. It's really engagement. And I kind of like it because I'm not looking for sponsorship. I'm not looking for endorsements. I'm not looking for some company to say they want me. I'm not going to drown you with 5 posts a day of me eating my breakfast. Here's my breakfast and how delicious it is. You've seen those. It's not me. I try to make it a little bit interesting and just comments on things. Sometimes people said that you say what we're thinking, but we're not allowed to say. And I'm okay with that because I'm at a stage in life where, what am I going to do? Get fired? That's probably a blessing in disguise, and then I can go do something else. But my partners and colleagues are very kind, and they know as an Australian we're a little bit unfiltered, and we just say what we're thinking. And so for me, it's just about being genuine and authentic, and having the dialogues and the interactions along the way, and that's how we can.
Yeah. I mean, personally, I've been using it for a long time, and I've seen a lot of benefits out of it. One of the most important things is basically the network that you build, especially if you have something
100%.
if you have something like clear in your mind about your goal or what you want to achieve out of this network. You get connected
100%.
to a very, very interesting group of people, and that builds up a lot of opportunities.
And think about, and Mohammed, I mean, how many neurosurgeons are there in the world? Like, if you look at the US, there's like 5,000, I think. And let's double it. Let's say there's 20,000, and let's say there's another 20,000 orthopedic spine surgeons, and then let's say there's 50,000 people in the industry. It's only 100,000 people, and so the interesting thing is I find when I go to meetings now, and I just walk around the trade display, I run into people and they say, "Hey, I saw you on LinkedIn," which is a very, very weird sort of. I don't know if I say, was it good or was it bad? And are you offended or not? And 99 out of 100 people are phenomenal.
That's interesting. I had similar situations where some people kind of stopped me in just in the corridor in the hospital. And I have seen one of your videos, and that's we started a discussion that personally I would have never started it if this person didn't see me on a video before.
Yes. Yeah. So you're right. Networking. It's and this is the world we live in now. Is that you're in your living room, I'm in my office, and we're connecting. And I'll run into a meeting somewhere. If I see you, I'll shake your hands, give you a hug, grab a coffee. How's life treating you? Yet we've never met. So I think that collegiality and networking is wonderful. And I'm a big fan of pay it forward. Be nice. The interesting thing about LinkedIn, and this, it's not what we post, it's our direct messages. It's the things that never get out there. It's people who reach out to us and say, "Hey, I really like this. You were there. This was fantastic." They don't want to say it in the public, but they just want to let you know. And so I find that sort of interchange really gratifying as well.
Perfect. And touching again on the social media, I mean, you see a lot of posts on social media discussing cases, and there are I mean, you can put them in two groups. One of them is people who want to have a genuine discussion about a case, but the other group are just marketing for their practice some way or another.
Oh yeah. Yeah. Kill me now if I see another endoscopy video. Okay. If I see another ALIF or an endoscopy video, shoot me right here. You're 100% right, and it's like, so no one puts their shitty X-rays up, right? They always put, "This is my best X-ray," and they all look like this. And invariably, it's the more metal, the better. And you've seen that. This is this construct I did, and there's 4 rods in here. There's an ALF and there's 3 TLFs. And you look at the preoperative X-rays, and there are some countries in Europe that are particularly aggressive on doing this. You know which ones. I won't mention them. But there are some countries that you see their posts and it's like, wow, that's so aggressive. So I think you're right. And what you touched on before is what's the motivation of people? And we're all searching for relevance. We're also we're all searching for validation that, hey, I'm good at what I do. And we all have this insecurity and this imposter sort of syndrome where we're not good at everything. But these sorts of things, when you can put up that X-ray and say, "Look how good I am," and you're not as good because you can't do this, that's one group. And the other group is 100% that. It's just advertising. And it's just, I don't know if that advertising works, but my New Year's resolution was less X-rays and less videos of endoscopy. And so far, it's what is it, January the 18th? I've not put up a single X-ray. And I stayed away from all of the endoscopy videos.
You know what? The thing that kind of frightens me a lot from these posts about the cases, especially when it's a marketing one, is when you get someone posting a case and he says that this is what I have done, and it sounds obvious that this is wrong, but he gets loads of comments, praising him for the work that he has done. But you end up with younger generations or someone who is interested to do something, and then he comes up on this thread of, okay, a lot of praise for something that is obviously wrong. That's dangerous.
Yeah, I mean, I see So in England, I'm sure, and in Scotland and Australia, you see this worn out degenerative lumbar spine with stenosis, and the patient's got leg pain, and you give them a laminectomy, and they do okay. But in some areas, that's a T10 of the pelvis. T10 of the pelvis with an ALIF and 2 lateral cages and pedicle screws everywhere and 4 rods and a kickstand. And so this argument, the deformity guys, everything's a deformity case. I think that's bullshit. And I think that there are patients out there who come in with what look like obvious deformities and they're functioning very well. And there are ones that their pain is what's causing most of their symptomatology. So I think, that there's the extreme and then there's the real world. And you're right. You can send the wrong messages to the younger surgeons. I mean, a posterolateral fusion still works. How many people have put up a posterolateral fusion? It still works. If someone wants to put up a posterolateral fusion for an L4-5 spondylolisthesis and said, I did this, patient's leg pain's good, and it's a year later and it's healed, hats off to you. And I think that's where we miss it. And I use that Australian term of it's a pissing competition where everyone tries to say, I'm better than you are, and this is the way to do it. And it doesn't matter. As long as the patient gets better, if we can give care that's cost effective and the patient does well, that's the end of the story. If you want to do a surgery that's $100,000 and it could have been done for $10,000, I think it catches up with you eventually, that sort of stuff. So you're 100% correct on the kinds of posts that we say out there, and that's not going to change.
And some people are kind of always worried about using social media just because they feel that some sort of authority in their country, like in the UK, is like General Medical Council, to come after them for some reason. Have you encountered any of these issues or problems?
Yeah. So I think de-identification is really important. So one of the things that we tell our patients is that, as they come in, their new patient paperwork is that we will use your media may be used for marketing and social media, your de-identified information. So they sign that on their initial intake. But I think that there's a professional way and an unprofessional way. Now, you've seen it and I've seen it. There are videos of people operating who are dancing and whilst there's a patient that's asleep, and that's just asking for trouble. So if we're doing a professional dialogue, a discussion, and we're talking about a case and you've de-identified it, I think it's okay. If you're going to put videos up of you dancing with scrubs on and there's a patient asleep behind you, I think that's where you're going to get into trouble. So it's probably a little bit of where you're, what is socially acceptable in your community. And certainly in our community, if we started doing that, then we'd probably be in trouble with our medical board.
So as like surgery is not always successful. I mean, it has, success and failure. Life is always also full of success and failure. And one of the things of social media that people keep talking about success only, not about failure. So my question to you, not just because not because you do that, but it's just a question for the audience, because I think people would learn more from failures rather than from success. What's your biggest fail or failures that you happened to you over time, and what did you learn from them?
So are you talking about cases?
No, in life.
Or are you talking about things that we've done? Yeah. Boy, it's an interesting question, isn't it? To me, it's always, life is about all these different roads you can go down. So I always envisage myself as the chairman of a program who was doing academic surgery, visiting professor, and doing lots of research and being credible. And if I was in England, getting a knighthood from the Queen or King. But I went down a different road. And if you ask my wife, and if we ask your wife, everything that's ever happened in life, like our partners can remember, and they play with it in their mind. I've never been like that. To me, it's always, I made the best decision at the time, and this was the outcome, and then I have to move on. And the bigger question on that is, would I do anything differently? I didn't end up being an academic, neurosurgeon in a private practice in a big institution. I don't think that was a failure. I think it just the path went in a different way. So I try to be kind to myself, because the thing about it is that if we're too judgmental on ourselves, I think that it's unrealistic. Could I be a better surgeon in lots of ways? Absolutely. Do I see it as a failure? No. I think that we're just shaping and reshaping and reinventing ourselves, and all of these little missteps we have along the way, whether they're clinical, and how we did a case, or whether they're professional, and I did this, I didn't do that. I think they're all learning experiences. So to me, there's failures every day, but they're kind of just learning experiences. Anyone who says they aren't getting failures is probably not being honest with themselves, or isn't taking them as hey, I've got to brush myself off and keep going. And that's what I do with the kids. When the kids have something, I said, there's something to learn from this. Not everything comes easy, and the things that are worth having take time. And my startups at the moment, they're failures. They haven't, for the amount of money I've put in, they've made this much money back. But I don't sit there and say, oh man, I just wasted $2 million. I wait and say, hey, I think we can still do this. There is a problem to be solved, and we're getting even closer to the end. So I try to be upbeat about it, and not dwell on things that happen that are negative along the way, and just take them for what they are, and then keep moving. I think that the key is you've got to keep moving. Learn, keep moving. Learn, keep moving. And as a neurosurgeon, there's cases where you've done one thing during that case, and it led to disaster. And it's usually like the last part of the kerosene, or you drilled when you thought this is kind of scary, but you did it, or it was bleeding so much and you were working through blood and you did something bad. We've all done it. But in the moment you did the best you could, and the next time you're in that situation, you say, "Whoa, stop! Don't do what I did last time." And I sort of talk about laminectomy. There's so many ways I've torn the jury doing a laminectomy. I've done a couple of thousand lammies, maybe 3,000-4,000. But I know every time I've torn it at this point, then I've torn it at this point, then I've torn it at this point. So now when I do those cases, it's like, okay, be careful here, you've torn it here. 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 And so all of those failures mean that my CSF rate has gone down because I've learned from them. And I think that's how you should view failure. You've got to use it as a learning experience.
Yeah. And on the positive side, what are the successes that you think, okay, you said to yourself, okay, you know what? Wow, I did it.
Oh man. I don't know. I just want to be a physician. And my dad was a physician, and I used to watch him, and he was in family practice, and patients would come out of his room and they were smiling. And so we measure success in different ways. It's the patient we helped who came, and they have no idea what you did for them. And some of the most difficult case, and you go, you know what? That person had no idea what we just did for them. So they're the successes in there. Your family, your children are your successes. The people you touch, your friends, your family. If you leave things in a better place than before you arrived, it's a success. So whether it's family, whether it's social, whether it's our profession, whether it's the patients that we look after, and that's what I kind of think is try to make everything. There's a lot of badness out there. So if you can make your parts better, then they're all successes.
Yeah, perfect. Now you founded and started SpinePoint.
Right.
I don't know if you have any other startups or companies. Let's talk about them. What do you do with SpinePoint, and why did you take this pathway and started a company?
So it was I got involved in artificial disc surgery very early on, maybe 2003 or something like that. And I got together with two wonderful Canadian neurosurgeons, and we put this company together. It was called Kinetic Spine Technologies. And the idea was to make artificial discs, and we had some wonderful patents, but we realized that to get them into the US you have to do what's called an IDE study. So it's a $30 to $50 million study. It wasn't going to happen. And we both put a bunch of money in, all three of us. And at some stage they said, we've had enough, and I bought them out and I took the company. Then I looked at this and said, is there a problem we can solve with this? And everything has to be, is there a problem that we can solve with this? And very specifically, we have fusions over here and we have arthroplasty over here. Is there anything in the middle? And really, as a spine surgeon, I would argue that the biggest problem as spine surgeons that we face is adjacent segment disease, because our index procedures are so good, but we can't correct adjacent segment disease. Is it genetic? Is it lifestyle? Is it body habits? Is it our technique? Is it one of a lot of different things that are in there? And one of the things was that I focused on was stiffness, modular plasticity. And I got interested in it because I used to do this thing that Medtronic had, which were plastic peak rods for fusions, and the patients did great, and adjacent segment disease seemed to be less. So there was something about stiffness that affected how patients felt and how patients healed. And it was something that could be in between an artificial disc and an instrumented fusion. So that's where the idea came from. And so I started adapting all these implants for low stiffness. And it took a while. I mean, we started at Kinetic Spine Technologies in 2007. I finally finished the final prototype through about 12 generations last year. And the stiffness testing was just above cancellous bone. So really low stiffness, lower than all the implants that are on the market. And now we're in the process of just finishing FDA testing, which takes forever. And the goal is to give spine surgeons an implant which is very low stiff, that can be used for fusion, but maybe it changes subsidence rates, maybe it improves fusion rates, maybe it changes the stresses on adjacent levels. So really the impetus came out of trying to solve a problem. And is that, can we stop adjacent segment disease? Can we do what we're doing better than we're doing? And so that's where it came from. And, the surgeons that I've talked to, that I've shown the implants to, it's been very positive reaction to it. And hopefully by the end of the year, we have them into the market. And there's one cage coming, a cervical cage, and then 7 products behind it, but it's all the same technology. And I think there's something about low modulus elasticity and low stiffness that's part of that whole stew of things that affect adjacent segment disease and our outcomes.
And just out of curiosity, I mean, a lot of the surgeons would have an idea, but how do you take that idea from that stage of just being an idea to your stage now, like that you might, hopefully you would have something in the market in a year time, or hopefully
Yeah. So I think that the short answer is time and money, and it takes longer than you think. And, this has been 10 to 15 years. It's been so long that there were 3 patents, the first 2 expire in 3 years. And the last patent lasts till 2043, but it takes longer. The second thing is it is expensive, and that's where if you've got friends who are doing it. I was lucky. I was an established neurosurgeon, and financially I was okay, so I funded it myself. But the bigger question is, if you think of an idea, it has to have a value proposition. In other words, it's got to have something that people are interested in that solves a problem. So I think just very basic, and I give presentations to neurosurgery residents on this sort of IP development. The actual process is pretty straightforward. You Google everything. There's a website, it's called Upwork. You can find someone who can do basic sketches and they can make nice sketches for you. You can find engineers online. You can find patent attorneys that are good and they'll do the patents with you and you can submit it. And then you can find engineering companies that will prototype it in plastic and then test it. So the actual process is pretty easy. It just takes time and it takes some money. The harder question is there value to it and is it unique? So if you think of an idea and say, hey, I've got this idea of something, the first question is somebody already done it. And I'll give you an example of, I thought of an idea of putting accelerometers onto our lumbar braces to see if our patients are compliant in terms of post-operative. How far are they walking before and after surgery? And then for the workers' compensation patients to see whether or not they're actually active and whatnot. And the interesting thing is, as you go into the patents and start searching it, Nike has the patents on all wearables like that. And so if you made it, it's a Nike patent. Nike's got, Fitbit patents and all the rest of it. So you couldn't do it probably without a patent violation. So to go backwards to the question you asked at the beginning, I think the answer is you've got to solve a problem. And, either it's going to be a technique or it's going to be a material or it's a design. There's always problems to solve. As spine surgeons, the problems that we see is soft bone, screws pull out. So I have this other startup which is behind it called Bear Claw, and I worked out how to make a pedicle screw go around a corner. And as you know, screws can't go around corners, which is how it got patented. Somewhere down the line, I'm going to finish that design, but I have a pedicle screw that goes around a corner and it has, the construct is 3 to 4 times better than normal. It solves a problem. When we do spine surgery, why do we need 4 screws for a level? Why can't we have 2? Why do we need 10 screws at every level when we do a spine operation? Can we have less? And so those basic questions that we ask that we take for granted, I think that's where you've got to start asking, well, we always do it this way, but do we need to do it this way? Can we do it another way? So most neurosurgeons, most spine surgeons are curious, and you learn your trade, and as soon as you know how to do your trade, you sit there and go, well, this is a bunch of crap. I wouldn't do this. But maybe I can solve it. And I don't think it's for everyone, because I think, 90% of startups fail. And it's like gambling. You have to use money that that's just gone. But I think if you can solve a problem, and you have an idea that'll solve a problem, then that's worthwhile chasing. And that's the hardest question. Does it solve a problem? And then the bigger questions become, is it a commercially viable problem? And, you may think of, and I'm trying to think of examples without thinking of an example, but a slight variation on something, but it's still the same thing, and it doesn't really add much value. Or you may think of something that is not billable. So in other words, it just costs more money to use. And we see it every time. You see it every time. Someone comes with the next greatest biologic made from the amniotic stem cells of fetuses from here. And, oh, by the way, it's $10,000 a level. And it's like, you know what? If I use this, then $10,000 just went out the window for the hospital, for whoever. And so there's the value I can't see. But if you can get something that solves a problem and it has some sort of financial viability to it, that's the key. And that's hard. And that just involves a lot of thinking. But it's just, hey, every day you see problems and say, we could do this better. How can we do this? And go from there.
And what are the skills that you think that you have gained through this process of development and being engaged in product development and, involved in the market and probably, and that sort of trying to get a patent. And so, all the business development side of things and do you think that these skills can be acquired through just being a neurosurgeon and doing your day-to-day job? Is it worth it?
Yeah. So, I think so to answer your last question first, as a neurosurgeon, you can definitely do this without having to take additional training. You can read, and neurosurgeons are inquiring minds. So one of the reasons I went back and did an MBA was I wanted to learn what the business hat is. And it's interesting, the business world doesn't think like us. When you get called in on a Sunday night and it's your child's birthday party, but you're on call, there's an epidural hematoma there, you just get in your car and you go. The business world's not like that. The business world, the answer is money for everything. It's money. And they have a very clear, everything is focused towards the fiscal side of it. And we as surgeons are altruistic and we are self-sacrificing, and those are priceless things for which you can't equate in money. So you have to learn how to put a different hat on. And the different hat on is the money side of it. And so I'll tell you the difference was, before the MBA, if I wrote up a business plan about my widgets, I would have talked about how fantastic this widget is. And the widget does this and the widget does that. Now what I do is, this is how much the widget costs to make. This is the potential size. This is how we get it to market. This is the name. This is the the channels of distribution. These are the markets we want to aim at. This is where we want to stay. So you learn the business side of it. And at the end of the day, I think it's just different skills that you learn. You could probably learn them just through experience. But what that did for me was fast track it so that when I speak to an investor, I don't think they care how the widget works. They assume that it works how you say it works. And you've got to dumb it down so a 5-year-old understands how it works. But they're interested in the business aspect of it. And the business aspect is, how much do we sell it for? What does it cost to make? Where's our market? Who's our competitors? What's the market size? And how do we get our money back? And can you write some projections on it? So you can do it, but having done the MBA, all it gave me was the confidence to do it. So that when I sit there and I do it, I know that the business person across from me is not going to bullshit me, and I can call them out on it. So I think, life is about just gaining more knowledge and experiences, and never going to be curious. And I mean, you're doing podcasts. If you talk to your mentors about, hey, I'm going to do podcasts, they would have said, you're doing what? But in 2025, that's what you do. And most of us, we sit in our car, and I get tired of listening to music, so I like to listen to a podcast to hear an opinion. Yeah. And so I think we're always learning. And so, yes, you can do it, but if you can get some sort of validation is the wrong word, but organized education to it, I think you're better off for it. And, I did it whilst I was on full-time, working full-time. I did the MBA online, and so it is doable.
Yeah. And there is always that debate about start a business and then do an MBA, or do an MBA to start a business. You probably, I think you started the business and then you did the MBA.
Did the MBA. Yeah, and I think the MBA fast-tracked it for me at the end, because it really forced me to focus in. So I'm very happy that I did it. And I think I may have floundered a little bit. So how do you get around it? Get some partners. Get some business partners. One of the best movies for startups that everyone should watch is BlackBerry. And BlackBerry is about the handheld BlackBerry and about the founders in Canada. Have you seen it? And there's the nerdy guy, right? Yeah. That's me. And then there's the business guy, and he's phenomenal. So the key in BlackBerry is the nerdy guy realizes he needs the business guy, and that's where they succeed. Well, right now I'm kind of both, which means I'm not good at either, but enough to get things going. So the answer for the person who doesn't want to go back to doing an MBA is find the business guy and partner with them. And that way you've both got your skill set and you do it together, and you share the journey, you share the expenses, share the pain along the way.
And there are big players in the market, for spine or neurosurgery in general. Would that be a target for you to have an acquisition of your company through one of these companies? And what do you think of how healthy is that for the market, for big players just acquiring everyone?
Yeah, it's a good question, isn't it? So here's the goal. The goal is, I want to put a device in your hand that you say, I like this, I want to use it on Monday for my patient. That's the goal. So that you say, hey, you know what? I like this cage, I want to use it because I think it's going to help my patients. Okay, so that's the overarching goal. Now, if this was 2000, what happened was you thought of an idea and you worked with a company and they worked with you and they developed it and then they took it to market. And so 70% of the world market is 5 companies now in spine, and they don't develop organically much anymore. It's all acquisitions. So they just buy stuff. So the day of you developing that napkin sketch, and that's the famous description in the Peabody with Medtronic of a napkin sketch of a device, doesn't happen anymore. And the only way a larger company will be interested in you is acquiring you. And so the business side says that in order for a large company, well, you can get it to market yourself, which is what you do. Then you get market share. And if you get bought out by one of the big 5 companies, then on the financial side, you probably succeeded well. Is it good for the industry? It's not. because you've got 5 companies out there, and what they're asking entrepreneurs to do is so hard, is not just think of the idea, but develop it, get through regulatory, make it work, get it into the market and get sales, and then we buy it. And the problem with that is I think it stifles innovation. So most of the big companies aren't doing a lot of innovation. It's all acquisitions. And I think in the big scheme of things, that's bad. And it doesn't matter what industry you look at. Look at Boeing and Airbus. Look what's happened to Boeing. There's 2 plane manufacturers in the world. And Boeing is going through what sounds like a shit show, with planes crashing and questions, but there's no other alternative. So anywhere that there's very few players in the market, I think it stifles innovation. And I think that's bad for us. And at the end of the day, you and I, we're at the coalface. We know what the problems are. Not some guy sitting in some office doing CAD diagrams. You know what it's like, and you know how hard it is to put it in. And, I'll pick up instruments and say, the engineer that designed this has never been in an operating room. And if he was here now, I would throw it at him. Not seriously, but metaphorically, and say, this is crap. But we're there. And so the innovations are going to come from people like you, the next generation of neurosurgeons and spine surgeons. But it's got to have a way to get out there. And if you've got to run through, develop it, prototype it, test it, FDA approval, local European approvals, get it into the market, and then take some of their market share, it's never going to happen. And the best analogy is Tesla. So when Elon Musk, the only reason that we have electric cars now is Musk made enough money from PayPal and a few other things that he could bankroll it himself, pretty much. And they asked the European car manufacturers, why didn't you guys get into electric vehicles before? And their answer was, we didn't need to. And if we did, we were just taking our own market share. So they didn't have to. So they didn't innovate. And he innovated, but he had the funding to do it. And so that's an exceptional story. But it would be awful if in neurosurgery, that's how we have to innovate, is have stories like that. So I hope it changes and that the ideas can get to the surface a little bit easier. But you're 100% right with 5 major players having 70% of market share in the world, and all of them just looking to acquire things. I think it is stifling innovation, and you see that a little bit. So, the products haven't really changed dramatically in the last 5 to 10 years.
So, touching on that, given the development that will happen, what do you think will be the most kind of groundbreaking innovation that would happen in spine, let's say over the next decade, or how do you see the practice going over the next 10 years?
Yeah, it's interesting, isn't it? So in the US, certainly everything is going towards outpatient, and it blows my mind. When I started practice, you had a lumbar fusion, you're in ICU for 2 days, you went home in a week. Now they go home in 23 days. The orthopedic surgeons are actually ahead of the neurosurgeons, and I see this. They do knee and hip replacements in the US, and they're home the same day. And, the busy joints guys do 10 joints in a day. 2 rooms, 5 in this one, 5 in this one, all of them go on the same day. So there's different ways that we'll innovate. Number one is our techniques get more defined, smaller incisions. Minimally invasive is that buzzword we've had forever. Endoscopy will probably take off and continue to have a role in there. I think navigation in some format, which is cheaper at the moment. You buy navigation and it's $1 million. It shouldn't be. Every spine surgeon should have access to navigation. So navigation makes things easier, makes them smaller. Can you imagine doing a convexity meningioma without navigation? I mean, I did it when we started training, but in 2025, no one would do it. You want navigation for it. So navigation becomes more widespread. Material changes, and you've seen it, that we tend to oscillate a little bit. We started with allografts. We went to PEEK for a while. And then we're in the solid titanium, porous titanium phase. Materials are getting better. So our materials get better. Our imaging gets better. Our understanding of biomechanics gets better. It's still messy. And, when it's all good and dandy when we sit in the office and we measure all the angles of what we want to do on this patient, and then you whack the cage in the operating room and you say, gee, I wonder if those angles are right now. Why can't we just see it there? And for all of our calculations, why are we doing calculations? why aren't there algorithms that we put our x-rays up and say, I'm going to put a 12-degree cage in here, and the little arrow comes up and says, thumbs up, that's good.
Yeah.
So this, we don't use slide rules anymore. We don't use log tables. It's all done in the background. And so a lot of that deformity calculations, I would argue, could be algorithmic and on the fly. And so that you can just take a picture of an x-ray, or your C-arm shot tells you this looks good. A simple example is, let's say you want 35 degrees of lordosis between L4 and S1. On your fluoro shots, we should know what our angles are at any time. Just regular fluoro shots. And whether that's an app that takes a picture of the fluoro shot and then the rep shows you and says, you're at 30 degrees. Do you think you could compress the rods a little bit? Now you got 35. Done. So the ease of doing things should improve. Diagnosis should improve. Access is an issue, everywhere. In Europe, it's an issue. In Australia, Canada, it's an issue. Cost has to come down. That's a huge issue in the US. Our indications have to get better. The US tends to fuse a lot more patients than I bet you Scotland does, and more than Australia does. So we need to get better on indication. So, I kind of think of it as an octopus, and there's all these arms going in different directions. There's material improvements. There's our instrumentation, navigation improvements. There's endoscopy coming through. There's better diagnosis. There's access issues, not just for patients, but for physicians. There's making, deformity shouldn't be, a witch's brew of calculations. It should just be, hey, this is good, this is not good, and go from there. And I think, we've seen it happen in our lifetime in other things. Nobody uses, you're too young to use dial-up internet, but we use dial-up internet and things like that, and rotary phones and things. Those things have to come to what we do on a daily basis. And I think that's exciting. I think the real interesting question is the effects of AI. And you've played with AI, and AI is not always right, but it sounds like it's right. And I've already had patients coming to me and said, we looked up AI. And so I had a patient with multi-level stenosis with OPLL, and they came to me and I said, okay, you need a posterior approach. And they said, we looked up AI, and anteriors are much more tolerated than posteriors. And I said, they are. Go and look up OPLL and see what it says about that. But that's the world we live in now, is where our patients have access and can question us, and it's hard to stay up to date with everything. And that's going to be one of the challenges is, can you be a general neurosurgeon and do everything? And so when the patient comes to you and says, what's the latest in hormonal treatment for my recurrent meningiomas? I don't know, but maybe I should know. And what are the genetic subtypes for this? So I think we're at an exciting time where we have access to knowledge at our fingertips, but we have to do things smarter, not harder. And that's, I think, my mantra is smarter, not harder.
Perfect. You talk a lot on social media as well about efficiency and making things efficient in the workplace or in theaters. Mm-hmm. I remember you talking about one day that you had 5 cases and you started like 7:30, finished by 2:30 or something like that. Right. That's something that I never managed to do.
You will. No, but you will. So what are the keys? Sorry to interrupt you, Mohamed.
No,
keep going.
I mean, my question is basically, how do you make it efficient, and how do you advise centers in general, like units or centers or big hospitals, on how to develop pathways and workflows to make things efficient and works better for the patients and for the surgeons as well?
Okay, sure. So the efficiency is 2 places, isn't it? It's you personally, and then it's your environment. Now, every time you get up in the morning, you have your ritual, don't you? I do this, then I do this, then I do this. My clothes are here, my car is here, the keys are here. That's my ritual. And so once you're further down the track in your career and you've done 1,000 ACDFs, 2,000 ACDFs, this is how you do each step. I always say ACDF, there's about 8 different stages to it. And each stage, from positioning to closure, there are pluses and minuses to every step we do. So if the positioning is bad, the case goes to hell. If your incision's in the wrong place, the case goes to hell. If you haven't undermined this, the case goes to hell. So every step you have to optimize. And that's just repetition. That's volume. So that's you. And you'll get it. Every surgeon gets it, and it's a volume sort of thing. And you'll be twice as fast as you were when you started out in 10 years' time. Then it's the people around you. And the people around you have to buy into your vision. They have to believe in what you're doing. So I'm blessed. I try to treat people nicely and kindly, and I don't try to take advantage and game the system. So I have phenomenal scrub techs. I have this scrub tech, and she's done our cases so often that she hands me the instruments in the order without me asking for them. And sometimes I've got the wrong order, and she's got the right order. And one, it's volume. And two is you treat them well. So I don't make my lines run till 7, 8 o'clock at night because people have places to go. Our room turnover will blow your mind, but sometimes it's 20 minutes. And at 7 in the morning, the patient's in the room. So my parts are be efficient in what I do. What does that mean? They know exactly what I'm going to do, when I'm going to do it. So the radiographers have a good idea of when they need to come back to the room to do the next shot, because we do it the same way. So you got to do it the same way every time. The worst thing is you keep changing what you do. And I see that in the junior guys. This week I'm using company X. Next week I'm using company Y, and I'm going to do it that way. Next week I'm doing this, and then I'm doing this. And what happens is your team never knows what you're going to do. And you should be able to tell your team, I need these biologics, I need this implant, I need this, I need that. And that way they feel comfortable because they know exactly how you're going to do it. And they'll get a cadence for how long it takes. So be a creature of habit, number one. Number two is be kind to the people you work with. And that's everyone from the people that clean the floors in your operating room to the people who organize the emergency lists. And if you do that and they buy into the vision you're selling, they take pride. Then it becomes a team effort. Then it's not, hey, I did 5 cases and I'm great. It's the team. We did it, and I always say, you guys make me look really good. And so I think the answer is inspire the people around you. Treat them kindly, treat them well. If you inspire them and they feel like they're part of your team, they will go to bat for you. And they'll make you look better than you should look.
That's a wonderful advice, and I would encourage everyone to do that, to be honest. And but it's as you said, building the habit is the most important thing to make things more efficient. What's your top 3 lines of advice for younger generation of neurosurgeons, spine surgeons out there, or even aspiring neurosurgeons like medical students, people who want to be surgeons? What's your top 3 lines of advice?
Oh boy, they're hard, aren't they? It's the kind of things that I tell my kids. Be kind. And it sounds very trite to say that. Be kind to your patients. Be kind to your colleagues. Kindness goes a long way. Work hard. One of the things that I took the greatest pride was I came back as a consultant at the hospital I trained at, and one of the other surgeons who trained me said to one of the registrars, he doesn't take any shortcuts. He does things the right way. And it was like, wow, that's really nice. The only reason is that every time I take a shortcut, I get burned, right? So he learned that. But work hard, and the last one is be organized. And be organized means, it's one step after another. It's worry about today. Doesn't matter what happened yesterday. Today's a new day. Look after yourself. And that's all the things we talk about are, exercise, eating right, being kind, surrounding yourself by good people. There's no magic to those. But if you're kind and you're doing this for the right reasons, and, the reason I got into medicine was I wanted to have a profound impact on people's lives. Now, as someone had said, if you want to help people and make them feel good, you can sell ice cream. And people feel small when they get ice cream, but the challenge is most of us could sell ice cream. Not all of us could be neurosurgeons. And so if you come into the specialty with the right intentions, ultimately, despite what happens, you'll be happy. And then you're not going to be complaining about how much money you make. You're allowed to complain, but then you move on. You're not going to complain about the work conditions because it's the next patient. It's when patients start coming back to you with their family members and they come back and their neighbor recommended you, that's why we did it. The reason we do this practice is to have a profound effect on people's lives. And if you remember that, and that's why you're doing it, if you're kind, you work hard, and you be organized, and you take it one step at a time, world is your oyster. You can do whatever you want. You make your own story that way. And I think that's the easy, you just one step at a time and just work hard and be organized.
Thank you. And I know that, correct me if I'm wrong, you have two girls and one boy, yeah?
I do. And my wife and I do not pressure them. So you're going to ask me the next question is, what do they want to do?
No, the question is, would
know.
you love to see them as doctors or surgeons or not? Or is that?
Probably. The world is changing, and it's harder to be a physician than it ever was. And you know that, I know that. And I see the struggles out there, and, there's mental health issues, reimbursement issues, respect issues that are out there. In our family, that's all we know. And my dad was a doctor. I was a physician. So my son is gravitating to it. But, my wife and I have this attitude that you just need a good education, and you have to be a kind person, and you have to work hard. Then you decide what you want to do. So we don't pressure them, and we'll wait and see what they do. But we kind of let them decide what they want to do. As long as they're good people, and the saying I always have is, your job is, and my job is to help them achieve this, is to be the best version of you. Now, it doesn't have to be a neurosurgeon. The best version of you could be anything. But as long as you're the best version of you, and you're kind, and the place is better because you were here, I think that's the goal. And, if we said everyone has to be a neurosurgeon, well, we don't need that many neurosurgeons, do we? We need family doctors. We need pediatricians. We need garbage collectors. We need accountants. We need dentists. We need everything out there. We need good plumbers. And if you are doing what you do, you love it, and you're the best version of what you should be, what you can be, then I think that's the success of life. So I would rather they're kind, and they work hard, and they're the best version of themselves, and then the rest will sort itself out.
And who's more difficult to raise, the boy or the two girls?
Depends if you ask me or my wife. Girls are I grew up as one of three boys. And Mohamed, do you have children?
Two girls, yeah.
So I grew up with three boys, and I thought life was pretty straightforward. Girls are challenging, I've learned, and I've learned that there's something called middle school in America, which is like 7th and 8th grade, and girls become very mean to each other during that time, and there's lots of drama going on with girls that I never knew happened. And with the boys, it doesn't seem to be as big an issue. It's much more straightforward. So I think it's a different challenge, and but when I get old, I know that the girls will be the one who will come looking after me, not the boy. The boy will be off doing something else. So it's it is what it is, and I'm grateful to have healthy children. That's the main thing.
And thank you very much, and thanks for taking the time to come to the video podcast. It's a lovely, interesting discussion, and I think I'll probably can continue going with that discussion for another hour.
I know. I hear you. Well, Mohamed, I want to thank you for asking me, and I think we need to hear from more people like you, and we need to get more voices out there, because we're not in ivory towers. We're normal people. We're dealing with normal problems. And if at the very least there are doctors out there that watch and listen to what you have to say and they take inspiration from it, then I think there's some value to it. So I want to thank you for setting this up so that people have access to it.
Thank you. And for our audience, please let us know in the comments below if you have any questions. I can forward it to Dr. Sekhon to answer you. And wait for and stay tuned for our next guest. We have a wonderful lineup of guests for the video podcast. Thank you.